Good day everyone, I am Sofia Michibi Ayaay, and for today we're going to perform Cesarean Section Traditional Technique. Indications for Cesarean Section includes dystocia, prolonged gestation, fetal malpositioning, and fetal death with putrefaction. Equipments to be used include standard general surgery instrument pack and suture, laparotomy sponges, clean towels, incubator or heat lamp. Pre-operative techniques include abdominal radiograph, lactated ringer solution, anesthesia induction, intubation to minimize the risk of aspiration, and a prophylactic broad-spectrum antibiotic such as cefazolin 22 mg kj IV. The patient must be in dorsal recumbency, and eventual midline incision is made commencing at the umbilicus. The length of the incision is determined by the estimated size of the uterus. The mammary glands are often hypertrophied, and the surgeon should not invade the mammary tissue when making the skin incision. The wound edges are protected with laparotomy pads moistened with sterile saline. The first uterine horn and then the second are exteriorized by carefully lifting through the incision. The surgeon should remember that the uterus is enlarged and should not be lacerated when the abdominal cavity is entered. So here, a small incision with a scalpel is then made in a relative avascular area on the dorsal or ventral aspect of the uterine body. So tend the tissue of the uterine wall to avoid inadvertently lacerating a fetus with a scalpel. So the uterine incision is then extended with medicine bomb scissors to a length sufficient for easily removal of the fetus. Move a fetus to the incision by gently squeezing the uterine horn. Once the fetus is near the incision, it may be grasped and gentle traction may be applied to facilitate rapid removal from the uterus. Open the amniotic sac as the fetus is removed for them to breathe. Direct fetal fluids away from the operative fields to minimize contamination. So as you can see, I'm opening the amniotic sac away from the incision to prevent the fluids from spilling. The umbilical vessels are then clamped and are severed approximately 2 to 3 cm from the fetal abdominal wall. This is then ligated. The neonate is placed on a sterile towel and is passed to an attendant. The associated placenta is then slowly removed from the endometrium by gentle traction to minimize hemorrhage. This procedure is repeated until all fetuses and placentas have been removed. Before closure, the uterus is palpated from the pelvic canal to each ovary to be certain that all fetuses and placentas have been removed. If the uterus has not begun to contract at the time of closure, oxytocin can be administered. Close the uterus with 2-0 or 3-0 absorbable suture material such as polydioxanone or polyglyconate with swage-on non-cutting needles for uterine closure. The edge of the uterine incision are carefully opposed with an inverting continuous Cushing pattern or a continuous Lambert oversew. Before the uterus is returned to the abdomen, the closure should be inspected and the uterus should be cleansed with warm sterile saline solution. Lavage the abdominal cavity with warm physiologic saline solution and aspirate all lavage fluid if contamination or spillage of uterine contents occurred. Non-absorbable suture materials such as polypropylene, nylon, or stainless wire may also be used to close the lineal aiba. The subcutaneous tissue is closed with 3-0-2-0 absorbable suture and the skin is closed with non-absorbable suture. A gentle controlled downward swing of the neonate may help to clear fluid from the upper airways by centrifugal force. The neonate is then vigorously dried because the skin stimulation stimulates respiratory drive in a reflex manner. While the mother is recovering from anesthesia, her mammary gland should be cleaned with warm water to remove any residual surgical preparation solutions, blood, or fetal fluids. The neonate then sucks colostrum from the mother. That's all. Thank you.